We can hear you, Jan.
Great. Okay, so welcome. I know this is how you want to spend your Saturdays. Me too. So first, just let me always apologize in advance for learning a new system. So this is the first time that Dr. Pap and I have used this system. In addition, I'm using a computer that's not mine. So it's going to take a little bit of, maybe some starts and stops, but we're going to figure it out from here. So I think we've got about 20 participants already at this point. So we're just going to go ahead. Oh, we got 22. So anyways, welcome. So this is the first time you've seen had us teach. We just teach once a year. We teach two classes. We teach oops, there we go. We teach two classes. That's this depression class and the PTSD. So we're both in private practice at this point. Dr. Pap is also faculty at UCSD, used to be full-time there at the University of California, San Diego, where he was in charge of the pain program and the ketamine program, but is now full-time private practice with me. We specialize in treatment-resistant depression and trauma, particularly pretty severe mental health disorders in general. We work out of two different clinics here in San Diego that we own one of them. So we really appreciate any sort of comments you have or contact. Like all of you, we're extremely busy, very full practices. So please just do through email, and we'll try to get back to you as soon as we can. Really appreciate it too if when you send us contact information that you put the class title in the email, so that we subject line, so we know it's you, and we'll try to respond faster than the rest of the junk mail we get. So I had sent out an email to everybody. Unfortunately, I only got half the class to respond. I had asked for 2 questions to be answered. This is for Dr. Pap and myself. None of it's going to go to anybody in the school, specifically with your name. Part of it is because this is a very disconnected sort of teaching that we do, and rather than ask you your favorite pet or something like that, we wanted to ask something we thought was relevant, and that's the 2 questions that we asked all of you to please respond to before the class. And the 2 questions are, what states are you licensed in? And then the second question is, are you pursuing prescriptive authority, and in what state? So I'm going to name the people who have not responded to me, so that you know that you need to send me an email, please, with those answering these 2 questions. If you did it to my original email, that would be helpful because I can see the subject line. So Abdullah, Amanda, Amber, Angela, Jason, Jordan, Juan, Maribel, Monica, I think it's Nahib, sorry if I'm pronouncing that wrong, Saruba, Shalib, again, excuse me if I'm not pronouncing your name correctly, Sherry, and Simran. All of you I expect to have an email from by lunchtime, so that I can collate our page. So it's one way for us to get to know you. So thanks to all of you that have already sent that. So here are the learning objectives. As you all know, we have to have the learning objectives for APA designation. We're going to be following that, as best we can. Some of them are a little overestimated in terms of what the learning objectives are. So for example, talking about the dietary restrictions of antidepressants, there aren't a whole lot, but we will cover it. But I would say this is a little lopsided on some things. One of the learning objectives that we have added and think are extremely important is about the current ideas about suicidality and relationship of depression and suicidality. So Dr. Pap and I have both returned from a current psychiatric conference, to psychiatric conference, where a lot of the information that we got there has been incorporated into our slides now. So it's changed quite a bit from last year. So excuse any sort of I hope, misspellings and things like that. We're working on it. It's just that it had to get it back into our presentations in pretty short order to get you the hottest topics on the psychiatric circuit. This is our outline. I want to point out that there is an error on your slide that says the outline. So we've switched the number 8 and 9. So monitoring and discontinuation and withdrawal will be done by Dr. Papp at the very end instead of the 8th presentation. So that one's going to be different on your slide. So Dr. Papp and I will be switching on and off between our presentations. In general, I'm going to be far more general in terms of how I talk. So it's going to be a good way to sort of lead into a lot of what Dr. Papp is going to be talking about. You know, some of the information will be unique to both of our presentations. So again, his slides are a lot more dense than mine. Part of that is because of the way that we're going to we have structured the exams. So the lectures themselves, again, there'll be lots of detail. The fact that this is often depression is placed first in your classes that are the advanced psychopharm. It's now, I think it's been put 5th or something like that. So you're going to expect that you're going to have a lot of this information. We might be doubling up on stuff, but we probably will be talking at a little bit more, I wouldn't say higher level, but more detailed level than your other lectures might have. So we consider depression, most people consider the treatment of depression is really the cornerstone of prescribing because of the medications. You probably all will see depressed patients in your encounters. And so you want to know that one really well. So anyways, the lectures, we're going to rotate back and forth. There's going to be interactive questions and some case examples, which we expect you to please answer the polls that have been created by our very competent TA. And those will come up within the lectures and be recorded for the class. So the exam itself, an open book. And when we say open book, we mean completely open. You can use anything you want. You can use tablets, you can use software, we don't care what you use. The only thing you can't do is ask somebody the answers to the questions. So I don't know how they monitor it. I think they probably have you on some video to monitor exams. So as long as you're not talking to someone, you can have anything you want. And in fact, we really strongly encourage you to have something where you can look up drug names, their dosages, their indications, all of that. So you don't have to go back and forth between the slides. But Dr. Papp is going to be covering a lot of that in his slides, and it's there. So the slides themselves are really the sort of the textbook and resource for you to look at. Hopefully there'll be something that can serve you later if you start prescribing or even if you don't. But we wanted the exam to be more like how you would function in the real world, where you really are able to look at anything you want. Within that exam, there are going to be case vignettes and objective questions as well. In the past, we've had just case vignettes be the dominant. We're not quite sure quite how the exam's going to go, but it will encompass both types of questions. We'll send out a study guide at the end of our Sunday class, and you can kind of use that as a guide. But again, you don't have to memorize things. You just have to really know how to find them quickly in order to answer the questions. So are there any questions right now about the exam or how the lectures are going to go? No. Okay. So just really briefly here about, depression. I'm sure all of you have seen depression, obviously in your practices or wherever you're working. I mean, it's the burden of suffering and financial loss from depression worldwide is pretty astounding. So it really, speaks to why we want to spend quite a bit of time on just depression itself. We can see here that there's 17.3 million adults in the United States that have had at least one major depressive episode. That's 7% of all US adults. You can see here Now I don't know if can you see my pointer of my computer or not? Could someone answer me? If I move it, do people see it? Okay, so you can see right here that women have more depression than men, and in fact is about 1.6 times higher than men. The difference in these prevalence rates are really well established, but not well understood. One recent study indicated that women also have an increased prevalence of atypical depression, comorbid panic disorder. You can also see the age, 18-25, quite a bit more than other age groups. This group here, who have 2 or more race or ethnicities, are really at higher risk for depression, the highest risk for depression. Sorry, I'm just working with trying to look at my own presenter slides by doing this at the same time. And then in adolescence here, we can see the age group here, 15 to 17, which has the highest rate in females, nearly 3 times the rate of males in the adolescent population. 12.3 million adolescents have at least had one major depressive episode, and 71% of them with extreme impairment. So the burden of depression is there. This very last slide, I just kind of like it, sort of the genetic vulnerabilities for mental health disorders. You can see the sort of overlapping sort of depression and anxiety in particular, quite a large area. And we're going to be talking, I know you've had the lectures about anxiety already, I believe, but it plays a fairly strong role within the depressive spectrum. And then of course this sort of overlap with bipolar and schizophrenia here too. So anyways, so we're going to go switch to the next slides. Let's see if I can actually make it happen. I think I have to go to new share. Oh. Okay, so now.
Where's the Zoom?
We're having sorry slideshow. Okay. Yeah. Okay, so in this this part of the lecture, we're really going to get to sort of more overview of the basics of diagnosis and treatment. And I know you all know diagnosis pretty well, but it's particularly important when you're prescribing to have an accurate diagnosis. So we can see here that the past year treatment received among adults for treatment, a large percent of them have had no treatment whatsoever. And then this group had both health professional and medication, but there's actually this group here with only health professionals. So not everybody is receiving care, obviously. And here, if we look at the adolescent population, even a smaller group are receiving treatment. And the reasons behind that are multifold, but I think it is pretty indicative of what's going on. So it's not really about just about the insurance reimbursement, why you are going to give a diagnosis of depression when you're prescribing. Giving a diagnosis in general is part of informed consent. Really justifies why you're prescribing that medication as opposed to not giving a diagnosis. It's going to guide the medication that you prescribe, not just for today or when you're seeing that patient, but hopefully into the future too. So it's really going to help give that patient an idea of the diagnosis into the future as well. So you all know that patients can be sensitive about receiving that diagnosis, but it really is part of this informed consent. So many diagnoses, many psychiatric and medical disorders really will include elements of dysphoria or depression, but that doesn't mean that an antidepressant is indicated. So just because there's a little depression doesn't mean you bring out your prescribing pad. So we're going to just start off here with a poll. Aidan, do you have the poll for these cases as well, I assume?
Yes, Doctor. Case of Maria. Although I couldn't put the vignette, people should read it from the screen here.
Yeah, that's fine. Okay. So we're just going to start with this case to kind of get your mind thinking. So Maria is a 55-year-old female. So I have to move the poll over. It's right in the middle of what I'm reading. Who presents 28 days after her husband was murdered during a robbery. She states she is unable to stop crying or have any feelings of joy. She has lost 11 pounds and has poor sleep because of nightmares. She has thoughts of suicide, although she states she won't act on the thoughts because she has children. I have no hope that anything will get better. I feel worthless in every part of my life, she says. So the question is, what would you do? The answers are A, treat with psychotherapy alone. B, explain that she is suffering from grief, but that she will get better soon, thus no medication is needed. C, treat her depressive symptoms with medication. D, treat her sleep issues, or E, C, and D. So let's get sort of an idea. Okay, so looks like the majority of people, okay, give it just a little bit longer. Okay, oops. So Aiden, all of the answers disappeared off our screen for the case.
I still see the answer. I'm gonna share the results once it's done.
Okay.
Would 2 minutes be fair?
Yeah, I don't think we even need 2 minutes. This is just a pre-test. We're going to go to it. So let's go ahead and see the answers. See how people voted. Okay, so the majority of you chose treat with psychotherapy alone. The next group was explained that she is suffering from grief, but she will get better soon. Thus, no medication is needed. So let's see what happens. Okay, so you can stop that poll, Aiden. Thank you. See, I'm going to have to. It puts the poll right in the middle of my screen. Okay, so we're going to step through some of the diagnosis, and then we'll go back to this case here, sadness, reactive sadness. So in this sort of case, this is just transient emotional reaction from sort of simple event. Here's the DSM diagnosis, or description of it, and really medication is not recommended in this dose. It's transient, and the patient is likely to get better. So now we're going to look at grief. So grief is a normal response to interpersonal loss. It's an automatic reaction, presumably guided by brain circuitry. It's not really an adaptive maladaptive response. It makes sense. There's environmental reasons. A 2-year course is not uncommon. So medication is not advised in this case. However, grief was removed from the DSM-5 exclusion for major depressive disorder specifiers. That means just because you have grief does not mean you should not have a medication. Sorry about that. I have to move this poll again. I can't even read it. So the subset of persons who meet the full symptoms, duration, severity criteria for major depression within the first few weeks after bereavement should not be excluded. So just because there's grief does not mean there isn't depression. Bereavement doesn't immunize the grieving person from major depression, and it is in fact a frequent precipitant of major depression. So let's look at the sort of differences here between grief and major depressive disorder. So with grief, there's just emptiness and loss, but in major depressive disorder, it's a persistent depressed mood. So this means day after day. This doesn't mean just transient depressed mood. And it's not tied to specifics. Nothing, they have negative thoughts about everything, not just about the death. So I thought grief was normal, but not to exceed 6 months grief to exceed. So I'm not quite sure the question there. So this is again talking about the most recent DSM-5, where grief, that specifier has been taken out. So they are allowed, they can have positive emotions, but in major depression, they have a persistent unhappiness. Self-criticism and pessimistic ruminations, worthless self-loathing, and suicidal ideation. As in grief, the death wish is focused just on joining the deceased, but the self-esteem remains intact. I'm looking at the questions. Yes, DSM-4 guidelines, but again, here's this DSM-5 guidelines, which are different. It's been taken out. So, persistent complex bereavement disorder. It's not a separate diagnostic category at this point. Complicated grief is really at the high end of the grief spectrum in both intensity and duration, and includes things like avoidance, maladaptive proximity seeking, ruminations that are usually focused on counterfactual accounts of the death. So that's really a different sort of presentation than just simple grief. Within the depressive spectrum, there's a lot of ruminations about worthlessness. So a persistent complex bereavement disorder. So one of the primary researchers on this is Sidney Zizok. He's on this paper here that's referenced at the bottom. He's here at UCSD, and we've had quite a bit of interaction with him. So if you want to look at some of his work about grief and bereavement, it's very good. So the last sort of category here is this adjustment disorder, PTSD, and medication in this case may be appropriate, particularly, oops, did I skip something? Let me go back to the persistent bereavement disorder. Sorry about that. So in this case, antidepressants may be appropriate. So depending on the severity of the depression, one would not exclude giving a medication just because they're in a state of bereavement. And then this adjustment at PTSD, gosh, I'm bad with these buttons, sorry about that. Medication can be appropriate depending on the severity level. That will be covered in the next lecture. So let's go back to Maria. What do you see about this case that makes it a little bit different than maybe simple bereavement? So does anybody notice anything particular? So first of all, we would say this is this is a murder that she's her husband is killed with. So right there, there's a natural death, a traumatic death. Right, so suicide, nightmares, and trauma, absolutely. So it's a more severe sort of bereavement. She states she is unable to stop crying or have any feelings of joy. So right there, she is not within the category of simple grief because she has no feelings of joy. So the depressive thoughts are not transitory. She has pretty severe somatic symptoms of 11 pounds lost and has poor sleep because of nightmares. So we're thinking maybe we've got, we got the severe physical symptoms that she might have something like a PTSD or traumatic bereavement. She has thoughts of suicide. So she has a protective factor, but she's not talking about just wanting to join her husband, the suicide. She's really not wanting to be there. So again, this is more the complex bereavement or major depressive disorder. She has no hope that anything will feel better. I feel worthless in every part of my life. So this is not simple grief. So medication, and particularly the severity of this case, would indicate what the answer would be. We don't need the poll again, Aiden. I'm just going to, sorry. I'm just going to give the answer in this case, is that you're going to do C and D. So C and D means you're going to treat her depressive symptoms with medications because of the severity of it. She has suicidal ideation. She has severe somatic issues. And then also you want to be able to treat her sleep issues. Now, whether you treat her sleep issues with a medication or with some sort of cognitive behavior therapy, that's of more, there could be differences in that. But this is not, you wouldn't treat just with psychotherapy or just explain it's just grief and it's going to go away. So any questions about that? Would an antidepressant help her sleep? It depends. Some people it does, and some people doesn't. But you want to think of sleep as an issue, and in fact, even the weight loss as issues that need to be treated. They're not just something that are going to be going away. Okay. Any questions about this case? So when you're reading these cases, you want to start thinking a little bit differently than you do. And I don't know, I wouldn't give meds from the get-go. Well, so, everybody has their different sort of takes on this sort of thing. But if you're going to go by what psychiatric guidelines on, it's very important to think a little bit differently than a psychologist might be thinking in this case, because we've got really pretty severe issues when there's suicidality and with the weight loss. But we'll be going over that later about what the standards are for psychiatric practice for medications. Okay. So now let's take another little pretest here. So we're going to talk more about continue to talk about the depressive symptoms of diagnoses. So in this case, of the following depressive disorders, which is most likely to necessitate a medication? A, persistent depressive disorder. B, premenstrual dysphoric disorder. C, major depressive disorder, moderate. D, major depressive disorder with atypical features. And E, major depressive disorder with melancholic features. So let's go ahead and answer that one. We got 80% have voted. Let's try to go for 100%. This is really important for you to be answering these questions because they're recorded. And in order to get APA accreditation, we have to have this sort of thing. So. Okay, we're stuck at 81%. So let's go ahead and move on from here. So it looks like the majority of you chose major depressive disorder with atypical features. The second choice was melancholic features, and the third choice for people was persistent depressive disorder, and nobody chose PMDD. So let's see the answer. So here we have major depressive disorder in adults. There are different sort of presentations along with their specifiers. With it, there's substance or medication-induced depressive disorder due to another medical condition, other specified depressive disorders, persistent depressive disorder, that's the dysthymia plus chronic major depression, premenstrual dysphoric disorder, and major depressive disorder. So substance medication-induced depressive disorder. It's going to be often overlooked cause of depression, but one which prescribers must be particularly aware, because if you've got substances going on or medication-induced depression, it's going to interfere with any sort of medication that you might be giving. So really the standard of practice is to treat the substance use concurrently with the medication rather than with the depression, rather than trying to parse them out in two different things. So whether the medication is necessary or not depends on the severity of this. So it may be appropriate depending on, again, on the severity. And of course, you want to treat with withdrawing from the offending substance. So if it's alcohol, which is really common cause of depression, you want to try to help them to reduce that alcohol at the same time. So we have a depressive disorders due to other medical conditions. This too is an often overlooked cause of depression. Dr. Papp is going to be going into it in detail. So the guidelines for this is if you have an older patient, if it's the first time they've had a depressive episode, if it's sudden, there are known medical issues or atypical symptoms, and for example, pain, many medications involved with their care, that's where it's sort of a red flag that you think medical conditions being causative. And one of the first things you can do now for all of your patients, whether you're prescribing or not, is to ask them when the last time they've had a checkup with their physician to rule out anything that might be medically related. Cancer, for example, is a very common feature to have depression. So in this case, medication may be appropriate, but you really also want to just think about treating the condition as well. So this is going to be a referral out to other people. So this other depressive disorder, it has to have some clinically significant distress. It's maybe not going to include all the features of it. So again, it's the level of severity that medication may be appropriate, but just because it doesn't fit in the criteria of major depressive disorder doesn't mean you have to wait. If it's severe, it doesn't mean that you have to wait till all the symptoms come up. You can still go ahead and treat with medication, depending on the severity and the specific presentations. Obviously, if there are known specific stressors, environmental stressors that are causing this sort of depressive dip, you might want to wait and refer to therapy in the interim to see if it clears up. So this persistent depressive disorder, which used to be called dysthymia, and with the chronic major depression on top of it. This sort of low-grade chronic depression, self-esteem, and where there's depressed mood most of the day, there's sort of this veil of sadness over people. So it's going to be look the same as major depressive disorder, but less severe and last much longer, at least 2 years. This sort of double depression that can happen, that's when you have a major depressive disorder on top of this persistent depressive disorder. And again, the level of severity is going to indicate whether there is medication prescribed. If it's just persistent depressive disorder, no suicidality is not one of the specifiers in it. So again, it doesn't necessitate a medications. Premenstrual dysphoric disorder. So this is the sort of typical symptoms of depression, plus these moodability, irritability, physical symptoms, which really worsens in the final week before menses and then will improve. A lot of women have it. So the finding, 5% of menstruating women, there's 2 times the risk between puberty and menopause. There was a finding that was sort of out there for people saying that 90% of women who successfully commit suicide or premenstrual is actually a discredited finding. They definitely, there is a higher risk for women, 5% of women that are going to get this. So the 5 symptoms in the final week before the onset of menses will improve within a few days after the onset and become minimal or absent in the week post-menses. So there's a great resource by here that's Balanced Women's Health. It's a psychiatrist that is treating premenstrual dysphoric disorder and other women's health issues pretty innovatively, and it's got some great tracking charts and things like that you might want to look at for your patients. So whether this is going to be treated with medication or not really, again, depends upon the severity. Here's a nice little chart actually from I think it was from, yes, from the same website. You can see this PMDD hazard zone. This is this week before the onset of menses, where there's more likelihood of this depressive element happening. So it depends on the basically the progesterone and estrogen levels. So the estrogen levels dip down here, and the progesterone levels are coming down. So major depressive disorder, you all know the symptoms of this, with depressed mood, diminished interest, which they have to have one of these twos in order for it to be major depressive disorder. And then there's, you need 5 total symptoms of either significant weight loss or gain, or increase in appetite, psychomotor agitation, fatigue or loss of energy, feelings of worthlessness or guilt, diminished ability to think or concentrate, and recurrent thoughts of death or suicidal ideation. So, and there's going to be significant distress or impairment in this with this diagnosis. So they're depressed most of the day. Nearly every day is indicated by either subjective reports or observations by others. So whether you prescribe medication or not is going to be dependent on the severity level of the depression. And of course, we're going to go over all the prescribing guidelines about when you really do prescribe for this. So I kind of like this little psychiatric review of symptoms. This is what's often used in the American Academy of Family Physicians. So this is what your primary care is going to be looking at, this SIDGE CAPS to identify depression in a primary care setting. So the medication recommendations, I kept talking about whether or not how severe it was, whether it's going to be recommended, but there are other things that we would look at too. So it's going to be the severity of the depressive episode, the lifetime course of the depressive episode, what state of remission it is, and the different characteristics. And then most importantly, really, is whether the patient is willing to take the medication. So even, the most depressed patients that come in might still be unwilling to take the medications. And of course, you can't force that on them. Okay, so just a minute, let me look at the things. I'm kind of not following and confused. Traditionally start with definition, etiology, symptoms, treatment, etc. It seemed it jumped into somewhere else. So I'm not quite sure what that question means, but we each as presenters do it the way that we think about psychiatry, and Dr. Papp and I, are kind of going back and forth. We're trying to give an overview here first, and then we're going to go into the detail. Okay, so here's sort of a, pretty easy guideline. So we've got the severity. So if it's mild depression, you're not going to give a medication. It's really not recommended. If it's moderate depression, it may be appropriate. So you can give it or you don't have to give it. Generally, you would want to combine psychotherapy along with any of these. So psychotherapy for mild depression, but if you're going to give a medication with moderate depression, you would add psychotherapy as well. And then, but with severe major depression, really, that's where you're going to think medication is first line. And I don't know about you, but I've certainly had patients that have come in, and you can work with them for years, and you just don't get anywhere with a really severe case of major depression. And sometimes just giving the medication allows them to have enough ego strength to be able to then be able to get some benefit from the psychotherapy. But of course, with severe depression, you would add in an ideal world, have psychotherapy as well. So one of the things you're going to look at, is this a single episode of depression, or is this recurrent? So depression tends to be recurrent. At least 90% of acute episodes reoccur. It's recommended, this is going to be a surprise to many of you probably, that it's recommended that there's maintenance medication if you've had 3 major depressive episodes. There's controversy, of course, about that, but that's the general guidelines that are for medication. So if the depression is in remission, in partial or full remission, so it's going to tend to be chronic. 20% of episodes are going to last at least 2 or more years, and that's a long time. So partial remission means the full criteria aren't met, or it's less than 2 months. Full remission means there's no significant symptoms for 2 months. So it's going to be very important for you to know these, we'll call them the 3 R's later. I'm going to put it out pretty succinctly for you in one of the later slides. In this case, again, a medication may be appropriate depending on the level of remission, but the general guidelines are to treat to remission. You don't treat to response, you treat to remission. You're going to hear me say this over and over again, and you're also going to, that's something you're going to know. So a lot of these things, as I told you, you're going to think of these slides as sort of guidelines for you, but some things I want you to really know, and that is treat to remission. Okay. So I'm not going to go into each one of these characteristics fully. You can look them up yourselves. You know, the problem with these lectures, of course, is there's so much to tell you, and we want to be able to, you know, share everything we know, but I know you can't take it all in. So go ahead and look these up if you want. But here, the characteristics, if they're melancholic features, medication is recommended. So melancholic, by its very nature, means you really have to have a medication. I say recommended because, of course, there's going to be some people that aren't going to take it, but just by the very nature of melancholic, it means severe. Psychotic features, again, medication is going to be recommended. Psychotic depression is something that needs a medication. At catatonia, I don't know if you've covered that in other classes, but if people are, can you explain melancholic features? So there's just, well, so Dr. Papp just informed me he's going to go over that more carefully about what melancholic features are, okay? So peripartum onset, atypical features, seasonal pattern, anxious distress, mixed features. It may be appropriate, but you have to have a severity level that really is going to indicate it. So just because it has some atypical, so atypical is going to be, you know, more sleep instead of less sleep, and anxious distress, maybe a little or not. It depends on the severity of it. So medication may be recommended. So you have had the class on anxiety, is that correct? Yes, okay. So there's certainly going to be some overlap here, but anxiety is such a common comorbidity with depression. It's worth kind of pointing it out when there's information about it. So major depression is going to occur in 40 to 75% of patients with anxiety disorder, and it's associated with more suicide attempts and psychotic symptoms in those with depression. There's also a specifier with depression called anxious distress, which in one study was met by 78% of the patients, and it's associated with a lot of increased disability. Again, Dr. Papp is going to be adding that to his lectures, but it's a very tricky sort of diagnosis, whether you have two things going on, something like, generalized anxiety disorder plus depression, or you have this depression with anxious distress. I actually have another slide as well in a latter part of my lectures. Oh, in fact, here it is. So the 5 constructs of the major depressive with anxious distress, and I actually have it posted for you. There's was at this poster session at the latest conference we went to. So it's posted on Moodle, I believe. Can't remember the name of it, but you'll find it. It's something about major depressive with anxious distress, and it really lays it out very nicely. But it's got these 5 constructs: really feeling keyed up, or tense, or restless, a lot of difficulty concentration because of the worries they have, this fear that something awful is going to happen. Oh, and the one I see often is this feeling that they might lose control or go crazy. I've seen that in my patient population. And with these anxious features, it's generally earlier onset, more persistent, more severe. So it's something, again, it's a kind of tricky diagnosis having that with the anxious distress versus generalized anxiety disorder. But when I've seen it, it's a more sudden course and very, very severe level of anxiety. Okay, let's go to our post-test. So, Aidan, do you have another poll for this one or not?
Doctor, if this is the exact same thing with the pretest, I just created into pretest post-test as one poll. If I run that again, it's gonna wipe out the previous answer.
Okay, so never mind. We'll just let's just get people answering on the chat, please, what they think the answer to this is this time. A, B, C, D, or E. Right, you guys got it. So the only one, just by its nature, necessitates a medication is melancholic. The others are going to depend more on the sort of the presentation of it and the severity level of it. Good. You got it right the second time. That's why we like these post tests. So I know you've had the bipolar class already. Am I correct? You've had bipolar? Yes. Okay. So again, there's going to be overlap, but this is such a crucial thing for you to understand that doing it twice is a good thing. So I'll talk fairly quickly about it. But this is a diagnosis you must make before you prescribe the antidepressant. If you want to make one big mistake, it's going to be prescribing an antidepressant to somebody with bipolar disorder. So bipolar depression without a mood stabilizer is going to be ineffective. It's going to lead to cycle acceleration. You can get a frank manic episode, and treatment resistant is not a good thing to do. So medication for bipolar depression obviously is recommended, but not with an antidepressant monotherapy. So it doesn't mean there can't be a antidepressant added to a bipolar depression regime, but you've got to have them stabilized first before you give them that antidepressant. So in general, if you're a little unsure about it, you're not going to give a tricyclic or an SNRI. The least problematic is bupropion, that's Wellbutrin. So if you have any doubt, starting with bupropion is a good choice because you're much less likely to provoke a switch. So unipolar versus bipolar depression. So the first symptoms of bipolar depression, of bipolar disorder that the patient presents with is usually depression. So, they're in their good mood, they're not coming into your office, or they're going to come in and not necessarily talk about that, the happy states they've had. They're going to come in for the depression. So it may just look like depression. 10% of those seeking treatment for depression have bipolar disorder. So that's a fairly high percentage that you've got to really be careful about finding. So the bipolar 1's got these longer cycles, and bipolar 2. Bipolar 2 so the longer, the older the person is, it just looks like unipolar depression because they're not really having any highs, and they may not remember any of their highs. So they're in your office, they're depressed. You've got to ask them the questions, particularly if you see some of the red flags. So 40% of the patients presented with bipolar depression are misdiagnosed with unipolar depression. Clearly, huge number. Average contact before their proper diagnosis is like 6 to 7 years. So we really wanted you to get collateral input, if possible, family members, if you can order records from other providers, that's good, because there's this state-dependent memory. They just don't remember about ever feeling good. So there are these sorts of things that you're going to see that seem suggestive bipolar disorder versus unipolar depression. The ones that I, see is these. So we've got these mood shifts independent of environmental stressors, some atypical features. They've got the family history of bipolar disorder. So that's when you do your, family history. The thing you really want to find out is if there's what are the psychiatric diagnoses of family members. If you hear, well, my aunt was just a little crazy, that could possibly be bipolar disorder. So sort of suggested of this bipolar versus unipolar is substance abuse, unstable relationships, suicides in the family, hospitalizations. They're kind of going to cue you into it. And a lot of comorbidity with substance abuse, migraines, anxiety disorders, those sorts of things. There's a nice little slide, this next one. I think it's the next one. No, it's not this one. So you're going to ask every patient with depressive symptoms about potential of having bipolar disorder. You're going to ask them those sorts of key questions, use collateral information, and then you do something like the MDQ. So pretty simple questionnaire asking about blood relatives. It's got some scoring about these different positive criteria. But even if they don't meet all the criteria for the MDQ for bipolar disorder, I mean, even a few endorsements should catch your attention and should have you on higher alert when you're prescribing an antidepressant. So if they say, for example, I always ask them about the shopping, right? So do you often spend money that you don't really, it's causing problems and you don't really need things? And if they do, it certainly could be a shopping addiction. It could be other things, but it's one of those things I would say is gives a red flag for bipolar. So here's the MDQ. The three things that I look at most, I think Dr. Papp agreed, to see if there's a bipolarity. And it's this spending money, so the shopping issues, and then asking if they've been more active than usual. Did you do more things than usual, more goal-directed behavior? And really the key question, the biggest red flag for me at least, is has there ever been a time that you got much less sleep than usual and you found you didn't really miss it? So if they tell you that they're up at 4 a.m. Scrubbing the floors, that's a red flag for you. So here's a nice little diagram I was talking about. This is from Stephen Stahl, one of the big guys in psychotherapy, in psychiatry, psychopharmacology, if you know him. So sort of suggestive of unipolar versus suggestive bipolar. So these particular presentations are ones that are going to be more likely to suggest bipolarity. Impulsivity, aggression, hostility for some of the symptoms, sort of this treatment history. And that should be one of your, when you're taking a really good history, they're going to have this history of worse response to antidepressants and antidepressants that induce hypomania, or actually get this worst response, it's sort of this poop out that it looks like. And then these other sorts of clinical history that you're going to see. Now, so we're going to talk a little bit, and it can be confusing. It's confusing where I keep going back for the slides. I'm really sorry. I'm not used to the system well enough. So this mixed feature specifier from the DSM. So it's going to be a major depressive episode plus a minimum of 3 other symptoms. 1/3 of adults diagnosed with major depression have mixed depression. 13 to 27, 20% of them will eventually meet a diagnosis for bipolar disorder, i.e. it wasn't really, might not have really been depression to begin with. Can be a very episodic condition that ultimately deteriorates into a chronic treatment-resistant depression. And it's really a very uncomfortable state for both, oops, I'm on the wrong slide when I'm talking about this, but these are the criteria: decreased need for sleep, but it's a very uncomfortable state for both. This is driving me crazy. Okay, sorry. Okay, I missed a slide. Very uncomfortable state for both patients and the clinicians. So they come to your office, they're just really agitated, they're on their edge, they're uncomfortable, and it has this high energy state. And this is a very tricky form of depression. And so you've got to ask yourself, am I treating depression or hypomania? But it's something that it should absolutely, open your eyes up and you start looking into what's going on. Just a minute, I've got a message. Try using the arrow keys. So let me see if the arrow keys, okay. I'm going to use the arrow keys instead of my mouse, and I think that'll keep me from going back and forth. Again, I apologize for that. So here are the criteria for it. So that's according to the DSM. So now we're going to look at this sort of alternative diagnosis that Stephen Stahl presents, this depressive mixed state. So it's a non-DSM-5 alternative diagnosis per Stephen Stahl. That there's this controversy that's existing as to whether the symptoms of depressive mixed states are fully captured by the DSM. So for example, depression plus this subthreshold hypomania and mania, it's really a little bit different in presentation, and you can be seen with any type of unipolar or bipolar depression. I'm looking at a question here. Do you prescribe mixed episodes similar to bipolar? It depends on whether it's bipolar or it's depression. That's why you got to really look at it. So, I mean, it depends. It depends, I would have to say. So this depressive mixed states, just a minute. Depressive mixed states that Stephen Stahl talks about, it's associated with a stronger family history of bipolar spectrum, rapid cycling, early age of onset, more females than males, a lot of comorbid anxiety, substance use, impulse control disorders. It's got a very poor prognosis and long duration of the illness, but look at that in red, it's at suicidality. So people who are in a depressive mixed state are at high risk of suicide. They have a lot of energy, they're agitated, they feel uncomfortable, and you just got to have your eyes really open for this state. So you're going to assess and diagnose very, very carefully. Here's a nice little diagram, again, from Stephen Stahl, a paper, and the paper is posted. So if you'd like to read it, I think it's worth reading. It's not very long, it's like 2 pages. But you really want to avoid any treatment that's going to worsen the hypomania or develop treatment resistance. So again, if you're thinking more by depression, you might want to be thinking something more like bupropion as a first start, because it's less likely to but it's actually going to cause more anxiety. So you want to be very careful with that. So you're going to be very careful in terms of your diagnosis. And Dr. Papa is going to be going over this more. So something like bupropion is going to be more agitating for them. But if you're going to do a antidepressant without a mood stabilizer on it, then you have to be very careful watching this patient. And if you really have the hypomania that is going to emerge, then you need to taper down or discontinue the antidepressant until they're stabilized on something. So I like this, again, I like this picture here, sort of this, it's got some overlapping parts of it here where you're not quite sure. And so, unfortunately, prescribing is that art. it's not a science. You don't have clear cutoffs for things. And so a monotherapy in generally is not recommended for these states. You're going to be super careful if you do it, but you're going to think probably mood stabilizer first. Oh yeah, arrow. Okay, so we're going to cover a little bit about suicidality, and then we're going to switch to Dr. Prapp. So we're going to take a little pretest, please. So which of these statements is false? So I guess, Aiden, we need another poll up.
So I'm trying to find out which one is this. This is a pretest. In which slide is this?
This is slide number 43.
Okay, on suicide. Okay.
Yeah. So which of these statements is false? Suicidality can exist independent of any other psychiatric disorder. B, over the last 50 years, we have not gotten any better at predicting individual risk for suicide. C, antidepressants in general have specific anti-suicide effect. Or D, suicidality is genetically linked. Okay, so it looks like we're kind of stuck here at, there we go, 18. Okay, so why don't we go ahead and move on? So it looks like the majority of you have chosen antidepressants in general have specific antidepressant effect, was the first choice. Second choice was over the last 50 years, we have not gotten any better at predicting individual suicide risk. And then the other two tied for third place. So let's find out the answer. So at a recent conference that we went to, there was a lot of new information about suicide. So I really suggest if this is something of interest to you in terms of suicidality, you look at David Sheehan's work. He's great, got a great ebook you can purchase and get all sorts of scales and things like that. So very fascinating sort of new information coming out. There's really an epidemic of suicide in this country that over and over again, the lectures that we have been in the last month attending talk about the increasing rate. There's one death every second worldwide. I mean, this is a huge number of people. The greatest are men greater than 65, and women is the highest during childbearing years, which is actually something I didn't know. I would have thought it wasn't. But it's a leading cause of malpractice. So if you want to protect yourself, this is something that you need to document, assess, document. Okay, so let's look at some of the most current. You see my little arrow there. That's a scary little arrow because it's that age group of adolescents. So since 2007, rates of suicide have increased in both sexes, but in adolescent girls more. 10 to 14 is the largest percentage increase, and the theories are that social media, more lethal means such as hanging and suffocations are going to be used. But you can see this here, this pretty fast rise. We can also see that there's a fairly high incidence in 85 or older, but the largest group is in the adult age. We're going to see a little bit more on the next page. So suicide is the 10th leading cause of death, and it's the second leading cause of death in young people. So the adults 25 to, middle age from 45 to 65 is this large purple area. Adults, this area here, 25 to 44. They are the largest percentage of people. You can see here males versus females. So 3.4 males for every female, and the largest number of uses are, of fatal suicides are firearms, suffocations, and poisoning. Interestingly, physicians and veterinarians have the highest suicide rate, which is, again, a little scary. So we can see the suicide rate by ethnicity. Again, whites are the highest suicide rate, followed by American Indian, and I see this pretty high, steep increase right here. Suicide death by method, again, we see firearms are the largest proportion of, which is not surprising to anybody. Okay, here's the kicker for all of you. So there's growing recognition that suicidality can exist separately from depression. So in fact, suicidality can exist even without any primary psychiatric disorder. This is going to be a surprise to you people. So some patients with depressive symptoms may experience consistent suicide ideation, but most do not. So really the current thinking on this is you're going to think of suicidality as an axis 1 or primary diagnosis rather than just being an element of depression. So here's about suicide and genetics. So half the predisposition to suicidal behavior is genetic and independent of genetic risk associated with major psychiatric disorders. So independent of genetic risk associated with major psychiatric disorder. So there's some ego-dystonic suicidality as well. So if you're interested, look this up. I think really one of the most interesting studies I've seen are about toxoplasmosis, where there's over 7 times risk of fatal suicide. So this is one of those medical cases. If someone has toxoplasmosis, you're thinking depression, right? So this is a slide by, again, David Sheehan that you can access if you want. And you can see that we've got depression, mood disorders, induced disorders is just one piece of the suicidality disorders. Yeah, we want to, he thinks of it more in the words of suicidality rather than suicidal ideation or behavior. So we've got PTSD, obsessive compulsive disorder, a whole broad spectrum of things that are associated with suicidality. Here's one of the most fascinating pieces here. This is this impulse attack disorder, including unexpected suicidal impulse attacks, USIA. So this is a sudden suicidality experienced as a sudden need or impulse, varying degrees of urgencies to plan or act in any suicidal way. It may be totally or largely unexpected or could not have been predicted to occur minutes before the attacks. So this means that if you believe that you can predict with suicidality with great accuracy because you know the state of their depression, you're wrong. So this is one of the scariest things I heard in in Sheehan's lecture, this recent lecture. So suicidality in general is individual suicide is not predictable. And we have not gotten any better over the past years at predicting suicidal act than it was 50 years ago. So there's this conventional wisdom that the Gottman scaling or staircase model is really predictive, but it's not. So that means basically if you answer one question in a negative about suicidality, then the other questions above it are not relevant. but really the suicidality is more this deterministic chaos model, where there's so many factors that are going on that you really can't predict it in this sort of more staircase model. And so you're going to think about focusing on reducing suicidality rather than trying to predict it linearly. So when you're assessing for suicide, you're going to track it every time, and then you've done your best. So you want to make your records really clear that if you have somebody that's any potential of suicide, that you've got that in your notes. You've got that notes every time, and then you've done your best, because we really can't predict it. You can't, again, this sort of about asking questions. Don't assume that you know one response from another. Skip questions or just use screening questions. You're not going to assume that you can predict the individual suicidality accurately, and don't freak out when a patient says they're suicidal. They're interviewing you, right? So if you freak out about it, they're much less likely to tell you the truth of what they're really feeling. So don't assume that this sort of suicidal thoughts is willful. It's the result of depression, it's attention seeking, or a personality disorder. We want to think about that the depression itself may be a suicidal trigger, but that stressors in the form of adverse life events really to be the trigger for the suicide attempt. So it is, even though depression has a height, is most likely to be associated with the suicidality, it's the adverse events that you have to be really most wary of. And you want to ask them, what is their most severe example of suicidal ideation in the last week or two? So in terms of treatment of suicidality, there are only 3 medications that treat suicidality. There's lithium, there's clozapine, and there's ketamine. So clozapine is a treatment for a psychotic sort of presentation. So really there aren't, the only 2 that are really left are lithium and ketamine. So ketamine now has come out as Spravato, S-ketamine, which Dr. Papp is going to be talking about. So Dr. Sheehan and I don't really know how strong this evidence is, talking about some sort of supplementations that can help with suicidality, high magnesium, low calcium. You can go to his website if you're interested in that. But really note this, that anticonvulsants can make it worse. So something like topiramate, Topamax is very well known that this is something that can make suicidality worse. When you treat with one of these medications and there's a rapid suicidality reduction, then the effect on the depression isn't necessarily as strong, including with ketamine. So here's a little information about ketamine. I've posted one of the articles about this particular study that was done, a very large data set with 235 patients, where the PHQ was used with the question of thoughts that you would be better off dead or hurting yourself was really the marker for how suicidal they were. So in this case, that ketamine infusions eliminate suicidal ideation in more than 2/3 of patients. I mean, that is a huge number. So I suggest you look at this if you're interested in ketamine. Dr. Papp and I are both involved with the ketamine community, and really the sickest patients had the most benefit in this case. But the ketamine that was used in this particular study was at much higher doses than the S-ketamine is now being used. So I just stuck in some resources if you want to know more about sort of the latest information about suicidality. Okay, let me look at some of this. Do you treat prescribed mixed up? Did you said MDs and veterinarians? Yes, they have the high. Oops. Yes, they had the highest. At least one of the articles I read. So when you say track each time, is it PHQ enough, or are you asking the questions each time? Well, the suggestion by Sheehan is you ask the whole set of questions each time if you have somebody at risk. Somebody, if you really want to protect yourself. Let me see, I'm familiar with ketamine for pain patients, and this population seems to decrease depression in some patients. No side effect of ketamine is increased fear, anxiety. No side effect of ketamine as far as I know, is not increased fear or anxiety. That's something I've never heard. So Dr. Papp is going to talk in quite a lot of detail about ketamine. And in fact, ketamine is now being used to treat some levels of anxiety and OCD. So I don't know that as a side effect. Okay, so let's go ahead and do the post-test about suicidality. So since I can't redo the questions, could some people tell me which answer they think this is, please? Oh, we're going all over the place. Right, so most people seem to get it right. It's C. The antidepressants in general have a specific anti-suicidal effect is false, because it's independent. So antidepressants, which are used to treat antidepressant, there are only 3 medications that are used to treat it. It is ketamine, it is lithium, and it's clozapine. So again, suicidality can exist independent of any other psychiatric disorder. It can come completely out of the blue. Over the past 50 years, we're not any better at predicting individual risk for suicide. And then finally, suicidality is genetically linked is absolutely a true statement. So it doesn't mean all cases of suicidality have a genetic origin, but it does mean that there's a strong association with genetics. So if you didn't get that question right, please make sure you go over the questions about the part about suicide again, because it's really important to, since it's one of the most common ways you're going to have a malpractice case if you're prescribing medication, you need to know it pretty well. So finally, I just want to have this so you can understand the sort of impact that suicide loss has on the survivors, that for each death by suicide, 147 people are exposed, and of those, 6 will experience a major life disruption. And probably most importantly, those who experience suicide loss are at a higher risk for suicide themselves. So I'm very involved with suicide loss survivors, working with that group. And with my patients, I ask every single patient about trauma, and I ask specifically, have you had anyone lost to suicide in your family or a close friend? And if you start asking that question, you will be surprised at the percentage of people who answer yes. So particularly if you treat trauma. So so we're going to turn it over to Dr. Papp. First of all, let me ask if there are any questions. Okay, so we're going to take let's see, 10-minute break. Do you want to take a break before Dr. Papp? So we'll just take a short little 10-minute break, and then it'll allow us to get set up. So let's do the 10-minute break. So we'll come back at 10:27. Okay? Thank you. See you in 10 minutes.
This is Dr. Papp. Can people hear me?
Can't hear you, Doctor.
Did it say can or cannot?
I don't know.
Can't hear
We
you.
can hear you. We can hear you.
Okay, all right. Great. Okay, so this is going to be a presentation about the causes of depression. Again, it's not going to be a very systematic presentation of causes. Just to respond to one of the earlier comments, we assume that you guys know everything that needs to be known about depression in general. So this is not a course on depression. This is a course on psychopharmacology of depression, and anything that we present is going to be presented from that point of view, with that in focus. And what Dr. Myers did in the first presentation is basically just laid the framework for the rest of the course, and focused on something that psychologists need to focus on. In my understanding, I'm a psychiatrist, so I don't really know how psychologists work in would work in this situation. But to a degree, I understand psychologists need to have some kind of a shift in thinking in terms of starting to think about medication, and so when to think about medication and when not to think about medication, and when to think maybe or maybe not about medication is an important point to emphasize for psychologists. Now again, I'm a psychiatrist, so I'm going to be presenting from a psychiatric or medical point of view, and I apologize if it's going to be, you know, alien or difficult or just you know, sounding something that you guys are not used to, but it's because I'm presenting the way I would present to a bunch of residents, psychiatric residents or other medical professionals. If you have any problem with that, please interrupt me and tell me what I should do different, okay? So here, causes of depression. Okay, so now it's not working. Depression can occur in response to two major factors, internal, external, or without any triggers. So it suggests that depression has both an environmental and a biological basis. Very basically, the etiology of depression will involve the genetic factors, this will be their nature, and the environmental factors, which would be nurture. And you see that genetic factors are somewhat less, environmental factors are somewhat more, that are the factors that contribute to the onset of depression. And there's an interplay or interaction between nature and nurture, which is known by genetics, like certain people with certain genetic makeup of parts of the brain that have to do with depression respond to environment and stresses differently. So this SERT promoter region is the genetic region that codes for the serotonin receptor. And there is a better version, there's a worse version, and people who happen to have the worst version have, and they undergo adversity, they have an increased susceptibility to depression. So these people well, I'll probably work in medical teams and familiar with prescribing. Now, I hope that at the end of this course, you guys will be familiar with prescribing, and that's what we are focusing on. Anyway, so to finish this thought, certain people with, so these people with the worst genetic makeup regarding this serotonin receptor, serotonin reuptake receptor, these people do not necessarily become depressed unless they have adversity. With adversity, they have a higher risk of becoming depressed than people who don't have that, that genetic makeup. Let's look at some of the biological theories of depression. And again, when I'm saying the biological theories, they are not here to supplant psychological theories. These are just different levels of description. Psychological theories remain just as valid as they are, even though there are biological theories. The biological theories with the brain theories, cellular and network theories, the ideas about different kind of neurotransmitters. We talk about the stress theory of depression, immune theory, and the gut theory that involves the microbiome. Again, everything is going to be sort of, just summary. There's much more about that than I'm presenting here. but these are going to be perhaps the most important aspects of the theories. What does cellular theory tell us about depression? What it tells us is that stress causes loss of synaptic plasticity via these two processes. There is this atrophy of the neuronal processes, the dendrites, and there's a decrease in the number of synapses on the dendrites. So if you look at these two pictures, I have a poll here. So this is a smaller magnification, and this is part of that magnification. As you can see, these are animal. These are from animal models of depression, of course, not from people. But you can see that the non-depressed animal versus the stressed animal, which will be the model for depression, this has a much richer dendritic structure, much more dendrites than here. There's a loss of dendrites. And on the dendrites, there are much fewer synaptic boutons, which are the way the synapse, the nerves, one nerve cell connects to the other. So there's fewer, and you can perhaps even see that they are smaller. And that's the result of stress. And as we'll see later, what antidepressant treatment does, whether it is psychotherapy or pharmacotherapy, it is going to remedy this and increase the richness of connections back towards more normal, both on the dendritic level and on the synaptic level. And that's going to be done by neurotransmitters, neurotrophic factors, inflammatory cytokines, and certain kind of steroids, which are neurosteroids that have effect on these brain structures. This is a sketch of what you see on these microscopic pictures. This will be a normal synapse. What these are, these terms may not really that important, but this will be AMPA receptor, which is a glutamate receptor. This is the brain-derived neurotropic factor, which helps the cells create more synapses. These are different kind of intracellular factors that promote cell growth and synaptic growth. And this will be the normal situation in an animal or person without depression. What stress does is reduces the availability of these factors, the BDNF and the mTOR, which is an intracellular factor. It makes everything less rich. The receptor, there's a down regulation of receptors. There is a decrease in size of the synaptic connections themselves. And it is because these intracellular processes are downgraded, and that's the result of stress. So that would be the stress or depression. So again, in summary, it means that the connections between cells are going to be less rich, both through the atrophy of neuronal processes, dendrites, and also via the decrease in number of synapses. Okay, any questions, please don't hesitate to post it. Okay, this doesn't work. The network theory of depression, this is becoming a more and more important theory. In the past decade, it has become clear that the brain has, and I'm not sure if it has been covered, but I presume you guys took basic neuroscience, so I think it should have been covered. There are these basic, not large networks in the brain, which all of them have different functions. The default mood network is the one that is active when you're not pretty much not doing anything. You're contemplating, you are resting, you are just thinking about yourself, remembering your past, etc. The salience networks that activated when you realize that something is important. And you see the structures in it, the amygdala and the locus cerealis. These are parts of the brain that respond to either danger, the amygdala, or allow the organism to become more active and turn towards the danger. And that would be the locus cerealis that creates agitation, anger, anxiety, etc. That might be helpful in situations like that. And then the central executive network, that is basically the one that works or becomes active when you are doing some goal-directed activity. These networks in harmony when in a normal person. And in chronic depression, what studies show that there's an interesting change occurs. Some connections within networks and between networks get weaker, and within networks and between networks get stronger in a pattern that is the pattern that seems to mediate depression. So the connections within the default mode network get stronger. So it means that it is more likely to get activated. And the salience and executive networks have a harder time suppressing it. What does that mean in terms of depression manifestation? That this is what the thinking is, that this is the way depressive recurrent ruminations occur. You can't stop the default mode network from being active. So just keep thinking about yourself, your problems, and you can't stop doing it. There's an abnormally strong connection between a salience network, so it means that the salience of things, and is usually the negative thing, is going to be increased and has an increased effect on the default mode network that's overactive anyway. And there's going to be a normally weak connection from the central executive networks, which means that it's going to be difficult for you with your own volition to think differently. So what medications do is, again, move the pattern back towards more normal, so reduce the activity of default mode network, weaken this connection, and increase and strengthen this particular connection. And I assume that you guys see my cursor.
Yes.
Okay. And again, what's interesting is that no matter what treatment it is, whether it's psychotherapy, whether it's medication, the traditional antidepressants, whether it's ketamine, the effect on this network is ultimately the same. Okay. Let's look about the neurotransmitters. Glutamate wasn't actually on the slides last year. It got onto the slides because of ketamine. So now we have a glutamatergic antidepressant. And just a little summary on glutamate. It is the most common neurotransmitter in the brain. There are different kind of receptor types. There's inotropic, NMDA, AMPA, and kainate. These are channels that allow positive ions to go through. And aminotropic, which work through second messenger systems in the brain. Glutamate signaling is abnormal in depression and any kind of stress-related psychiatric conditions, for instance, PTSD. Acute stress increases it, and chronic stress decreases it in the way that they lead to alteration in the glutamate receptors and the glutamate synapses in the way that was shown on this particular slide. And again, these are detectable with imaging studies. And glutamate is basically what you get in MSG, because that is glutamate. That is the actual neurotransmitter that you can buy in this bag. GABA, again, this was not on the slides. the reason why GABA is on, because now we have a GABAergic antidepressant, which I'm going to talk about. But again, it has been shown that GABA levels are reduced in the plasma and other kind of parts of the brain, by the body, in acute depression. And as with any other biological marker, the reversal of that is seen when you treat people with antidepressant. Even if it's not a GABAergic antidepressant, you can see the normalization of this function. Again, you have the same response with the GABA receptors, usually GABA-A, with respect to chronic depression that you see with the NMDA receptors. What it does is it leads to reduced inhibition, because as you know, the GABA receptors are inhibitory. So there's reduced inhibition as a result of these changes in the hypothalamus pituitary complex. And that's behind the increased cortisol release that you see in chronic depression and chronic stress. And finally, the chronic stress depletes neurosteroids that work on the GABA receptor. GABA receptor has a steroid site, connecting site. And these steroids, when they connect to the site, make the GABA receptor more active. One of the neurotransmitters is allopregnanolone, which is created from progesterone, so it's a sex steroid. And these are positive allosteric modulators, or PAMs, of the GABA receptor. Can anybody tell me what other PAMs are positive allosteric modulators of the GABA receptor? No. PAMs like diazepam, lorazepam, temazepam. The reason why they're called PAMs, they're the PAM at the end, because they have the exact same effect. Positive allosteric modulators on the GABA receptor. Just a little tidbit, okay? So what does GABA have to do with depression, and why I'm showing this slide? Because the medication that is approved for depression is approved specifically for postpartum depression. What happens in depression, this is the pre-pregnancy situation. There's a certain level of GABA receptor activity. It has a tonic inhibition on brain structures, including the hypothalamus. And there's a certain level of allopregnanolone, progesterone. Now, during pregnancy, the progesterone and allopregnanolone levels increase hugely. It means that in order to maintain the same amount of tonic inhibition, the activity level of the positive modulation of the GABA receptors has to be decreased. So that sort of maintains the same balance. Now, when parturition, which means basically giving birth, when that occurs, there's a huge and very, very fast drop of the progesterone and allopregnanolone back to normal levels. But it means that somehow the activity of the GABA receptor has to recover to normal levels, so to maintain the same tonic inhibition. Now, if that doesn't happen, that would lead to postpartum depression, because then the GABA receptor activity remains low. The tonic inhibition on the pituitary system that is described in this slide does not happen, and depression occurs. So if you basically get either medication or the same hormone you can put inside the brain, then you can increase the GABA receptor activity back to normal and the tonic inhibition back to normal, and that would lead to the elimination of depression. So this is very new. These are new theories of depression. I mean, they're not new, but they're new in clinical practice. Now, this is our old monoamine theory of depression, which is old but still true, but certainly not the only theory anymore. One of the lectures that we attended recently at the conference that we went to, Dr. Myers, had the title of Faded Love, the monoamine theory of depression. So yes, the love is not what used to be, because there has been so much, it is clear that there is so much failure with these traditional antidepressants, and Dr. Myers is going to describe it in great detail when she talks about the STAR-D study and other studies of depression treatment. But nevertheless, this theory states that the pathophysiological basis of depression is due to the deficient activity of monoamines in the CNS, central nervous system. And this is what you hear sometimes people say. So depression is low serotonin. I mean, it is of course oversimplification, but there certainly is something to it. And I think there is a little quiz coming up. Which one is not considered a monoamine? And for help, these are corresponding to the. So can we put this slide up? I mean this quiz up? Thank you. Let's see if we can reach 80%. One more. Good. So this is not a post-test, pre-test thing. And I tell you that the, keeps popping back anyway. So glutamate is not a monoamine. It is an amino acid. So if you remember from chemistry, this is the acid part, this is the amino part. So this is an amino acid. These are all monoamines because they're. This is very annoying. So these are monoamines. I mean, it's not very important, but I think it's just a good thing to know. These are all monoamines. You see the single amine group, the single amine group, single amine group, the single amine group. Okay, and don't forget melatonin is something gets created from serotonin in the next two more steps on the same pathway that creates serotonin from tryptophan. And you can see the very close, okay. You can see the very close resemblance. So they're just a few things added here and a few things added here. And you get melatonin from serotonin. Okay, so glutamate is not a monoamine. That's why it is not under the monoaminergic theory of antidepressants. So what are data supporting the monoamine theory? That virtually, I should have probably said virtually, but this is from Dr. Stahl, but he should have said virtually any monoamine reuptake inhibitor is an antidepressant, whether the FDA think it is or not. Tryptophan, which is the basic chemical from which serotonin is manufactured in the body. And again, tryptophan is a essential amino acid. The body can create very little. So some of it has to be, a significant part of it has to be coming from the diet. So if you take tryptophan out of a diet, then you can trigger depression in people who are in remission. Who are in remission from depression. or in healthy people who have family history of depression. So you take serotonin out of the system, out of the brain, then you can create depression in people who are susceptible. Low levels of 5-HIAA, which is serotonin metabolite, so that when the body breaks it down, then that turns into this chemical, which can be found in the CSF, which is central. CSF is the cerebral fluid, cerebral spinal fluid. Then these are associated with associated with high increase of suicide, risk of suicide. So again, people who have low serotonin levels in the brain, of which this is a marker, are the ones who have increased risk of suicide. Again, doesn't mean that they are depressed. Dopamine, which is another monoamine in this substantial nigra, Parkinson's disease, where there's a great loss of dopamine in the brain, highly predisposes people to depression. And also deficiency in the methylation pathway, the pathway that leads from serotonin to, from tryptophan to serotonin, can also lead to depression, not just actually removing serotonin from the equation. And that's why certain chemicals that we're going to talk about later have antidepressant effects. And then these are the data that have been accumulating in the past few decades that are telling us that this is really not the only story about depression. If you do studies with depression, they actually find 20% of patients in studies do better on placebo than on the antidepressant that's being studied. That is pretty shocking. I mean, I don't think that I have this slide here, but no. But there are studies that show, I mean, probably have seen these studies that drug companies do, and there's the placebo effect. Oh, can I do, I should be able to do something. Can I write notes? I mean, can I draw lines? Let's see, draw.
I think if you go to the lower left and click on that little pen in the lower left corner, you can do it.
Oh. No, I guess not.
Doctor, if you go to the upper bar, the collapse bar, they're gonna give you some options of the pen and etc. inside the zone.
Yeah, this I see this blue squiggly line, and I click on it, and then nothing happens. Okay.
I think you have to put your mouse button down and then drag it to
All right. Anyway, I'll just explain. So just look at my.
Go ahead.
No, I need that.
Let me just do this. Maybe that'll fix it.
No. Okay, so imagine this is the placebo line, and this is the treatment line. So you see that there is a separation from placebo, and that's how these medications get approved. Like you can prove that there is a separation from a placebo. But if you look at, you see, separate the medication arm. Separate the medication arm into those that are responding and those are not responding. This would be the responders. This would be the placebo, and then this would be the non-responders. So you can see that there's a significant percentage of people on the treatment arm are actually doing worse than people who take I'm sorry, we just have some military planes going about overhead here. So, apologize for this. Anyway, so the fact that a significant number of patients do worse on active medication than placebo is certainly an interesting thought. A very large percentage of patients with major depressive disorder have a chronic or recurrent course, even when they are treated with the antidepressants. And again, Dr. Myers is going to discuss it in painstaking details, the ins and outs of that. Not even 100% adherence to taking a medication makes any difference. So there's a study with people. There's a study of people taking the medication exactly as prescribed, 100% every single day as it was prescribed. And there were a whole bunch of other people in a different group who were taking it maybe like, with between 50 and 70% adherence rate. And there was really no difference in the time to relapse time. So there's the length of time which needed to occur before the relapse. And again, we're going to discuss it even in more detail. But that's one of the reasons why these new antidepressants are coming into play, because of the limitations in the traditional antidepressants. So what these traditional antidepressants do, the SSRIs, etc., as you see that you give, as you know, or probably know, you give this medication at a certain point, and then you're going to see a fairly immediate change in the cells that they are affecting. So the reuptake inhibition is going to occur very quickly. The second messenger system is going to kick in very quickly. But then it takes a long time to get to this level where the BDNF gene expression increases. So the BDNF starts to get increased in higher, gets produced in higher levels, and then start to create more dendrites and more genetic synapses. But if you give a medication that has an antidepressant on this point, then you see the antidepressant occurring right away, because it increases the BDNF levels, increases synaptic proteins within a few days, increasing neurons and dendritic synapses within a few days. So whether you give these kind of medications or these kind of medications, the end result is the same. So the SSRIs, TCAs, etc., eventually get to this point, but very slowly. And there's a whole bunch of other things can occur in the meantime that thwarts the process. There's a lot of steps here that can start readjusting themselves. Tolerance develops, other factors start coming in. And this is what the newer antidepressants completely take out of the picture. But again, I'm not saying that you don't need these medications anymore. That's one of the reasons why all these medications are being approved right now by the FDA as add-on medications, because this is still the mainstay of antidepressant treatment. Depression treatment. Okay, so let's slice the pie in a different way and look at a few theories of depression that are more ideological theories. One of the most important parts of a stress theory, that if you ask a patient why you're depressed, then vast majority of the times it is going to be stress that is going to be cited as the cause of their depression. Stress, which is a function of the cortisol system, is abnormal in depression, unipolar depression. There's a hyper secretion of cortisol, and as we saw, one of the reasons may be that there is less GABA inhibition on this system. There is abnormal diurnal secretion of cortisol. There's usually a high morning and evening difference. But if it gets narrowed, then there is almost constant cortisol effect in the body that has an effect on mood. It has an effect on sleep. It has an effect on appetite, which are going to factor into the symptoms of depression. Because of cortisol hypersecreted, this is just historical. That used to be something to torture psychiatric residents with on board exams. But if you give dexamethasone, which is a kind of artificial cortisol, to a normal person, that is going to suppress the cortisol level in the body because of negative feedback. And people who have a certain form of depression, mostly melancholic depression, do not respond with this change in cortisol level with dexamethasone because the system itself is hyperactive. That was something that used to be used theoretically, at least in 10, 20, 30 years ago. But again, the fact that it has this, it can be actually shown in clinical practice if you're interested. It underlies the importance of this particular system. If you give antidepressants, then it yet another brain function that is going to be seen as normalized. You're going to see childhood adversity has a negative effect on this HPA axis. And there are some experimental approaches targeting this particular system directly to reduce the, to block the these cortisol receptors with the hope that it is going to have an antidepressant effect, but so far it has not turned out to be clinically significant. HPA is the hypothalamo-pituitary axis. So the hypothalamus, which is ancient structures on the base of the brain, connected to the pituitary, which is even lower, and it sort of like hangs out from the brain. And that's where many of the hormone-regulating hormones are produced. So for instance, and I get to this, what CRH is. So CRH, for instance, is cortisol releasing hormone. This is one of the hormones from the pituitary. And cortisol is released from the adrenal glands in response to CRH. And then cortisol feeds back to the brain and it reduces the amount of CRH. CRH is being reduced, so this is a negative feedback system. And you have very similar mechanisms for thyroid. There is TSH, which is a thyroid stimulating hormone, which comes from the pituitary and then affects the thyroid glands. There are the adrenal hormones that has to do with water balance, etc. So the pituitary has these regulating hormones that regulate the activity of the peripheral endocrine glands, and that's the axis, that's the function of the pituitary, and that is connected to the hypothalamus via a little bundle of nerves. Okay. Much of depression is, let me just look at something else. There's only so much you can do in humans. And just a little bit, to be a little bit helpful, if you read literature of depression studies, there are animal models of depression, which are, if you think about it, it's really fairly anthropomorphic. You imagine that the animal feels depressed if it does this or if it doesn't do something else. And there, of course, there's debates going on in the animal experimental literature, whether this is how valid it is, but this is what we have. So the behavioral correlates that you can see in living animals, and there are the neuropsychological, neurophysiological correlates that you have to kill the animal for and then look at their brains. So the behavioral correlates, and there are many more, but these are the ones that are used most frequently, is the reduced mobility in the forced swim test. So you put a rat or a mouse in body temperature water, and it's the high walls in this container, and the poor animal can get out. So they swim and swim and swim and swim. Eventually, they stop swimming. If you make an animal quote unquote depressed, then they stop swimming sooner. If you give them antidepressant, then they again swim as long as they swam before. So that's the reason why it is animal model of depression. Okay, I just noticed a question. I thought CRH is released from hypothalamus. No, nothing is released from the hypothalamus. Hypothalamus is connected to the pituitary, and it is from the pituitary where these hormones are being released. There are other factors in the hypothalamus that affect these hormones in the pituitary, but I don't want to get into the complications of that. CRH is the cortisol releasing hormone, and it releases cortisol from the adrenal gland. Just as TSH is the thyroid stimulating hormone that stimulates the thyroid gland. And these are hormones acting on the peripheral endocrine system. Yes, there are hormones that are acting on the pituitary, but again, I don't want to get into that. And frankly, I probably don't even remember anything, because the last time I read about it was in medical school. Another behavioral correlate, which is seems to be a putative measure of anhedonia, is sugar preference. So give animals sugar and they love it, just like us humans. And if they're depressed, they don't love it as more. If you give them antidepressant, they love it again. So these are some of the ways that you can study depression in animals. And these are the ways antidepressants are being studied before they get studies in people. So let's say you give an antidepressant to an animal, it swims more, so it's okay, that's an antidepressant. Then you can see if it's not toxic enough that you can try in people, etc. Neuropsychological correlates, these are the ones that you can again see in brain slices. You can see that there is a reduced hippocampal neurogenesis. It's one of the most important findings in depression. Over and over again, this is one of the actual brain mechanisms by which depression occurs. Sometimes I lose my cursor. Underlying this is the reduced expression of proteins associated with neural growth, such as BDNF and CREB. And again, I'm not going to get into that, what it is. You guys can look it up, but it's just a summary of this topic, which leads to reduced dendrite, which is reduced dendrite length and complexity is the one that we saw in one of the first slides, and reduced spine density, which we also saw on one of the first slides. Immune theory. Immune theory tells us that immunological processes have a role in creating depression. Now, this is an interesting theory. Part of the theory is an interesting idea. It's called the sickness behavior. So sickness behavior, let's say you have an infection, or you ate bad food or something. And then what you do, you become withdrawn, you become uninterested in things. you may become irritable, you may have trouble sleeping. So some of these symptoms of being sick in general share symptoms of depression. And this theory says that this is not simply a superficial resemblance, but it means that some of the processes that occur in depression are the same processes that occur in sickness. So in a way, it is sickness without sickness. It is sickness when you shouldn't be sick. That's how I understand it. And the sickness behavior is mediated by these proteins called pro-inflammatory cytokines, which are small proteins that act on immunological cells, and then immunological cells create immune responses. And the immune response in different kind of organs is the basis of the sickness behavior. And these are animal studies that show that anti-inflammatory medications such as aspirin or ibuprofen or Celebrex can actually potentiate the effect of antidepressants. I think personally that if it was a really strong effect, then it would have come out already. People would say, well, take aspirin and my depression is gone. It is not really happening. However, I have to tell you guys that once I had a patient who swore to God that it was Celebrex that made his depression better, nothing else. And he had chronic pain. But it was not just the pain that went away. Actually, he was still in pain, not as much though, but he was still in pain. But Celebrex, 400 milligrams, he was taking so much that it was destroying his kidneys. He had to be stopped, but then eventually they restarted because that was the only thing that helped him with depression. So it is a little clinical vignette that I have seen myself, that actually, yes, these NSAIDs, these pain medications that are anti-inflammatory can actually help depression in some people. I wouldn't say that it's a very strong effect, but certainly there is something behind it. The microbiome theory of depression, this is something really not used in clinical practice a lot, but this is the theory behind using probiotics. And right now, probiotics are not FDA approved and FDA regulated, but I was saying at some point they will be, because a lot of science is being done on this area. There's a gut-brain axis, so whatever happens in the gut has an effect on the brain. There's just a little tidbits from interesting animal studies that, I think it's pretty interesting that you put fecal transplant, which is a nice euphemism for from depressed patients, into rats, and it produced depressed behavior such as reduced time on the swim test, exposure to stress and depressive behavior such as reduced swim test in rodents was associated with the reduced gut flora richness and diversity. And again, this would be an example where a probiotic would have an effect, positive effect on anxiety, which is sometimes, can be a sign of depression. Okay, so think about it. Again, these are important things to keep in mind if you, let's say you cannot prescribe, but you want to recommend something to the patient that is over the counter. This actually can be useful. Reduced hippocampal neurogenesis is just getting into more detail about the hippocampus. The antidepressants can both prevent it and reverse it, both the traditional antidepressants and the new ones. As I discussed before, can be the exposure to monoaminergic at a low response rate, and the acute exposure to the newer medications. And these are the delay times Interestingly, ECT, electroshock treatment, also increases neurogenesis in the hippocampus much faster, much stronger than antidepressants. That's one of the reasons why ECT is so powerful, so powerfully useful, and that's why it's acting so fast. And in fact, I'm jumping the gun here, but to this day, ECT is the most effective treatment for depression. Just a summary, again, slicing the pie in different ways, talking about neurotropic factors themselves. And this is an image of BDNF, like a sketch. The degree of decrease in BDNF correlates with ratings of repression in the brain, again, animal studies, and the degree of increase is associated with the alleviation of depression. The volume loss is, which you see in hippocampus. And again, don't forget that when you see that there's less and less and less dendrites and less synapses, that means that the overall volume of the nervous tissue is less. And you can see that on the brain imaging studies that the hippocampus actually gets smaller. So the lesson from this is that chronic depression is neurotoxic. It destroys connections both on the macro level and the micro level. Antidepressants, both psychotherapy and antidepressant medications, are activating, I can't see it because there's somebody, are both activating natural processes. So if you want to think about it, and patients ask, so why would I take an antidepressant? It's unnatural. Well, what they do is they activating natural processes. They activate the growth of dendrites and the growth of synapses. Circadian factors. It is clear that circadian factors have a great impact on mood. You can see that because light therapy has antidepressant effect, acute sleep deprivation has antidepressant effect. When I was a resident, I still saw chronically depressed patients in inpatient units simply being not allowed to sleep, maybe allowed to sleep 1 hour. And night after night after night, they couldn't sleep, and the nursing staff made sure that they didn't sleep during the day. And sometimes it helps people get out of depression. So acute sleep deprivation has an antidepressant effect. Agomelatine, which is an antidepressant, unfortunately not available in the US, that is a melatonin agonist, has antidepressant effect. Now, on the flip side, depressant effect is seen from chronic sleep deprivation, such as obstructive sleep apnea, or in medical illnesses that causing pain and discomfort. Question: can you prescribe fecal implants from non-depressed? No. I think that there are fecal implants that are being done. I don't think it's done for depression. I think right now it is FDA approved for gut diseases such as Clostridium difficile infection, C. diff, or ulcerative colitis, with the great effect, but I just recently read a death that occurred as a result of fecal transplant, so it is definitely not a innocuous treatment. But again, at this point, it is only in an experimental phase in terms of Well, I mean, yes, but you see, you are tongue-in-cheek, but you're basically anticipating the future because it is already being prescribed for another condition. And as you see, treatments that have been approved for other things eventually find their way into depression. So it was actually not as tongue-in-cheek as you intended. It was intended, but it may not be in the future. Sex differences. So as Dr. Myers mentioned, women are much more likely to become depressed. There's a differential sensitivity to stressors. This is what males are more sensitive to. These are what females more sensitive to. These are the sex differences in males and males and females. Again, the type of social stress. There's a differential sensitivity to that. And there seems to be a differential sensitivity in the types of antidepressants as men may respond better to TCAs and the women may respond better to SSRIs. The hormones themselves have a role in depression, and in fact, it has a clinical role because sometimes you can use these some hormones for the augmentation of antidepressant treatment. Androgens, testosterone. You can use testosterone as an adjunct treatment in men for depression, especially if the level is low. Estrogen replacement shows antidepressant effect, but of course it has other problems of causing uterine cancer. And allopregnanolone, the medication I described before, and comes from progesterone, pregnancy-related sex hormone, modulates BDNF levels, and adult neurogenesis, again, in our favorite brain part of the hippocampus. Now this takes us to a little quiz. Which of the following is true? Hypoactivation of the default mode network is typical in depression. Males are more likely to become depressed than women. Stress is cited as the leading cause of depression by patients in treatment. The monoamine theory of depression is no longer valid, and increased BDNF in the hippocampus is a sign of neurotoxicity. So we need the new quiz, please. Can we put the quiz up so people can actually respond on the quiz? Aiden? Okay. Okay, so the vast majority of you guys got it right. It is the hyperactivation of the default mode network that is typical in depression. That's the basis of rumination. Nobody chose that. It's correct. Nobody chose that. It's correct. This increased BDNF in the hippocampus is a sign of recovery from neurotoxicity. It is decreased BDNF in the hippocampus or other parts of the brain, which is the sign of neurotoxicity. Okay, good. So let's switch gears a little bit and go to the medical causes of depression, which is a different kind of causation. There are two kinds of medical causes. They can be caused by diseases and can be caused by physicians. That is treatment. Hopefully, the second is something that you're going to see very infrequently, but I'm sure you're going to see. So this is a non-exhaustive list of medical conditions that can be accompanied by depressive symptoms. On the top are the most frequent ones and the most important ones to know. Pain, by far, I mean, one of the most important factors, and there are two kinds of pains that pains that can chronic pain. Most frequently, one is skeletal pain, either from arthritis or fibromyalgia or stuff like that, or cancer. And there's a bidirectional causation, so pain can cause depression, and depression can cause pain. It doesn't cause cancer, but it can cause pain. Chronic sleep deprivation is something that can actually cause depression. One of the reasons why you always have to look for sleep disorders when somebody is presenting with chronic depression. And then the endocrine illnesses are thyroid and pancreas, especially pancreas meaning diabetes, and all the others, okay? Read them, I'm not gonna read them. But the bottom one is important. These are things that you're going to look for in your workup when somebody is not responding to treatment or has chronic depression, and these can be supplemented with vitamins. And on the next few slides, this is going to be a recurrent theme: observable and discoverable. So I'm doing a little medical thinking here. So when you prescribe medications, you have to start thinking a little bit like a physician. So you observe things, and then you follow up the things that you observed. Well, of course, in order to observe them, you have to be aware that they exist, and you have to have some recognition capacity that you see something and you know what it is. But one of the most important things to do in prescription, in medical treatment in general, but in prescription of antidepressant in particular, in order to avoid making mistakes, and I would like to emphasize it very, very highly, you have to follow cues. So you observe something, a sign, a symptom, and then you follow up on that, and you can discover additional things about that if you ask. So that's going to be the nonverbal thing that's observable that you can see on the patient, and then you start asking questions. And those questions have to be targeted to what you observe. So chronic pain, like I said, there's a bidirectional connection, and it is especially tight between depression and fibromyalgia. I think actually that fibromyalgia simply is a symptom of depression, kind of depression which is where pain is very prevalent and not a specific diagnosis, but it's just me. Don't quote me on that. So what is observable? If somebody comes in with pain, you're going to see that you're going to see pain behavior, like grimacing, fidgeting, strange posture, holding themselves in a different way to avoid pain. Antalgic gait, which simply means that pain is walking is painful. So you see that patient walks in and is limping, uses these devices. So then what you can discover that patient is in fact in pain if you ask. You can discover that the patient is on disability, the patient is taking opiates, and these are very important things to know if you're treating a patient with chronic pain. Let's look at the next one. Sleep disorders. Obstructive sleep apnea is not an infrequent disease. 45% of them have depressive symptoms, and they're often not responding to antidepressants. So you're going to see patients who are chronically depressed. You can give them any antidepressant you want, even ketamine, and they're not going to get any better because the underlying problem is the sleep apnea, and it needs to be corrected. And one of the things that a few things observable about it, but you can observe the patient is irritable. I forgot, but maybe you can add the patient is yawning a lot because just tired. So that also would be observable. And that was discoverable. You ask, do you snore at night? Do you fall asleep during the day? Do you have any trouble in your marriage or job because of the irritability? Because of the inability to stay asleep, to stay awake, and it creates problems on the job. And then you can develop a suspicion of sleep apnea. And if you have a patient where you developed a suspicion of sleep apnea, you will have to refer the patient to a sleep study. Now, it is not something patients like to do. I don't know why. Because I never had to do it, so I don't know why. I don't know how I would respond, but it's something that patients, the compliance level with that recommendation is usually low. But you should not give up, and you should keep pestering the patient. Have you done the study? Have you seen the patient? Have you seen your doctor? Make sure the patient keeps the appointment. So you have to be very, very diligent on that issue, because that can make the treatment of depression is completely hopeless. It's not going to be a very deep depression, but it's going to be very difficult to treat depression. And you're going to see obesity is something that might be observable, but there are patients who are absolutely not obese, and they have obstructive sleep apnea. So that is not, doesn't, so if you see a skinny patient or a normal weight patient, doesn't rule out the obstructive sleep apnea diagnosis. Other sleep disorder, the chronic sleep deprivation, you can suspect it in certain kind of occupations and lifestyle. But again, don't forget, acute sleep deprivation can treat depression and can cause mania. Somebody says, except if they are athlete. I guess I missed the context. I heard the masks are much better. Yeah, masks are better, and there's nasal masks that just go on the nose and not the mouth. So that's, yeah, they are better. But I cannot underemphasize the importance of this, because many times patients come to you with this complaint of depression, and it's not going to get better unless the sleep apnea is being treated. And then when it's treated, then you have to be on the top of them, ask them, are you using it? Because many times they stop using it. Okay, so just be aware. Thyroid illness. Now this picture, this pair of pictures is an old picture. It is extremely unlikely that you're going to see it to the severity that this picture this depicts. But hypothyroidism can result in depression. Yeah, some of the symptoms are the same, energy, cognitive sluggishness. Cold intolerance is a very characteristic symptom. So you see a patient that comes in and wears warm clothing in the middle of the summer. That's a pretty important sign. And the edema is, it's more severe, and it's unlikely to see it nowadays. Animal studies may show positive correlation between T3, T4. These are the peripheral thyroid hormones, and serotonin levels of brain. So if you increase these, people with low thyroid hormone levels in the serum may have low serotonin levels in the brain. And if you increase thyroid hormone levels in the serum, you may increase serotonin levels in the brain, which of course has antidepressant effect. This is the rationale between one of the augmenting treatment choices that we're going to discuss later. Female endocrine disorders, polycystic ovary syndrome or polycystic ovary disease is fairly frequently a condition that leads to depression. Usually it is the kind of mixed depression that Dr. Myers has described. And these are the observable signs. Usually there's some obesity, hirsutism, which means that there is As you see, there is little mustache on the face, acne, which you can see here. And then you can ask about, and you figure out and find that the patient is infertile, there's irregular menses, and of course, depressed mood and irritability are symptoms. PMDD and postpartum depression are not considered medical disorders. They are considered reproductive mood disorders. Type 2 diabetes. Let me just look ahead so I don't run out of time. Okay. It's a very, very frequent medication, and if it's well controlled, it does not interact with depression, but uncontrolled type 2 diabetes does. So it is important, again, if you see a patient and there's diabetes, then you have to make sure that you stay on top of that, and you ask about it, and you encourage the patient to take care of his or her diabetes. Likely mediated via the inflammatory effect of hyperglycemia, chronic hyperglycemia. It activates the cytokine system, and this is what you see. Patient comes in obese, carries sugar, drinks foods. Looking down, see the patient in the waiting room, and there is a huge bag of chips in front of him. And then you ask the questions that are diabetes-related questions: increased thirst, increased urination, or simply ask if taking diabetes medications. But again, don't be satisfied with taking diabetes medication. Ask if he takes the medication regularly. Ask if he sees the doctor regularly. Ask if the blood levels are what they should be. Sometimes you have to do a little medication management in this kind of a vicarious way, especially in situations when the medical condition can lead to depression. So you understand that if a patient's diabetes is out of control, that it may worsen depression. And of course, when depression gets worse, it can also worsen diabetes, either directly because it magnifies the inflammatory effect, and also indirectly because it interferes with the patient's ability to comply with the anti-diabetic medication regimen. Disorders affecting cortisol levels, peripheral disorders. So we are past the hypothalamic-pituitary axis here. This is here just for the sake of completeness, because can be too little and too high peripheral cortisol levels. I just put it here because it has to be here, but it's not something that you're ever going to see. Cushing's disease or hypercorticolism, however, is something that you might see. There's a primary condition that is causing it, adrenal adenomas or stuff, but it's also much more frequently in response to chronic steroid treatment. And there are people with autoimmune diseases who are on steroids and prednisone usually. And chronic steroid treatment leads to a characteristic change in the body habitus. It leads to essential obesity. So the face, the neck, this is called the buffalo hump on the back. Big, really big stomach, but the hands and the feet are, and the lower arms and the lower legs are not as fat, not as full of fat as they would be in a normal obesity. So it's a different kind of obesity. So if you look at it once, you know that this is a hypercortical patient. How do you find it out? You simply ask, do you take prednisone or anything like similar? And you have to understand, we talk about it later, that prednisone itself has significant psychiatric comorbidity. Immunological disorders can lead to depression. multiple sclerosis, lupus, etc. And sometimes you see chronic skin rash. For instance, this is a lupus rash. You can see it's called a butterfly rash because it's the two sides and goes over the nose. And then you ask about things like any pain, any fatigue, and these are chronic fluctuating symptoms, malaise, chronic low-grade fever. If you see this and the patient has never seen a physician, then you have to refer and see if they can make a diagnosis. Brain lesions, TBI. It's actually fairly frequent, unfortunately. Sometimes you're gonna see patients who have had a history of severe TBI, severe head injury, and significant late consequences. But sometimes you're gonna see patients who had a concussion and they already forgot about it, especially in the first 3 months after a not necessarily severe concussion. People can look like depressed. There is obtundation, which is like lassitude. There is there's a lack of energy. There is people look depressed. They look sad. They get cognitively impaired. So it can look like depression. So it's something that you should always ask. Have you had any recent brain injury? Brain tumors, sometimes brain tumors are, the first presenting sign is psychiatric. It is usually psychosis, but sometimes it is depression, so keep it in the back of your mind. There are many other medical conditions that can lead to depression, and it is something that you will probably discover accidentally. It is not something that would come out in any kind of normal psychiatric treatment situation. Okay, any question? Because the last few, before I go to the last few slides. No. Okay. Dementias can be accompanied with depression. Usually the initial phase of dementias where people have some insight lead to a more agitated type depression colored by anxiety. But as the dementia becomes more pronounced and the insight is gone, that it is more a biological depression. It is very frequent in Alzheimer's disease, and it's a little bit less, but also still quite frequent in stroke victims. Left-sided stroke is the one that predisposes people to depression. Interestingly, right-sided stroke with not as frequency, but it can predispose people to hypomania. Again, many symptoms of depression and anxiety overlap. You're going to see the restricted motion in the body, psychomotor activity is reduced. You're going to see the reduced expressivity in Alzheimer's disease. You're going to see things like tremor, if it's Parkinson's related. You're going to see simplistic speech, forgetfulness, reduced volume of speech. And the discoverable signs of dementias, besides collateral information, is that what you're going to get from on numeric scores of these different kind of scales that you can do them in a mental state exam, the MoCA slums. I mean, do people know what these are, MoCA slums?
Some do.
No. Okay. Yeah, so these are questionnaires that you can download from the internet, and these are like 20, 25 questions, cognitive questions, paper, pencil kind of things that patients have to do, and there's a numerical scale, and it gives you some kind of numerical rough estimate of the level of dementia. Now, when you see this, watch out for pseudodementia. What is pseudodementia? Pseudodementia is dementia seen in depression, especially in the elderly, where the reserve capacity of the brain is not as much as in younger ages. But there's a great of course the difference itself is one is dementia, one is not. And the treatment is going to be drastically different. So it is very important to differentiate between dementia and pseudodementia. And sometimes you have a patient comes to your office and is complaining about cognitive difficulties, even telling you that I'm afraid I'm going demented. So they themselves are going to use the term. But what you never do is just accept whatever when a patient's use statement like last at face value. So you have to follow up and figure out whether it's really dementia or pseudodementia. So in the really dementia, you can see a progressive onset, like years, slowly developing. While depressive dementia, pseudodementia, it has a rapid onset. So maybe in the past 2 months, something like that. With long-term complaints of forgetfulness, short-term complaints of forgetfulness. On the other hand, in pseudodementia, the depression is going to be constant. In dementia, when it's associated with depression, it's going to be variable. In dementia, and this is an interesting point, patients who are demented, they try to conceal their dementia. They try to answer the questions, and usually not perseverate, what's the term? I'm sorry, there's a term for that. It doesn't come to mind. If you know, please let me know. It's when you don't know the answer to a question, and then you give an approximate question. So let's say, well, so can you give me your address? Well, I live down the street by the post office. So that would be an approximate answer. In pseudodementia, the answer would be, I just don't know. I don't know. I have no idea. An important difference is that pseudodementia patients are complaining about the amnesia, lack of memory. So in fact, this is the symptom with which they may come to your office. And in dementia, patients are going to conceal it. They're not aware of it, and they will say, "No, I'm fine. I don't have any problems." And dementia, you will see the constant cognitive decline, and pseudodementia, you will see a fluctuating cognitive impairment. What you do differently? Obviously, if you have a patient with dementia, you're going to refer out to neurology for the treatment of dementia, but you're going to treat the depression if, let's say, you have a patient like that. In pseudodementia, you're going to treat the depression. You're not going to treat the dementia because they don't really have it, and as the depression gets better, the cognitive difficulty is going to improve. And this is just a final slide about the iatrogenic causes of depression. Certain kind of medications like prednisone, interferon, which is used for liver diseases, Accutane, which is used for acne, chronic opiate treatment, different kind of pharmacokinetical interference. So give a medication is going to be an enzyme inducer, and suddenly you find your medication is not working anymore. And Chantix, which is used for treatment of smoking cessation, all kinds of different kind of miscellaneous medications, anti-HIV medications, etc. Iatrogenic malabsorption is something that happens when a patient has a bariatric surgery and suddenly the medication doesn't get absorbed and it's not working. And the patient who has been stable on depression, say an antidepressant, suddenly becomes depressed again after bariatric surgery. And just a little reminder that medications, one of the iatrogenic causes of suicidal ideation is the antidepressants themselves, especially under age 24. So we have a final quiz. Which of the following is true? Aidan, if you would be kind enough to put it up. Pseudo-dementia is characterized by lack of insight. Acute sleep deprivation is a frequent cause of depression. An overactive thyroid gland is a frequent cause of depression. Hormonal diseases can be suspected in an overweight person who is depressed. And depression is rare in Alzheimer's patients. Let's wait one more. All right. Okay, so D is the correct answer. It keeps popping back up. So pseudo-dementia, it is dementia that is characterized by lack of insight. Pseudo-dementia is characterized by patients complaining about having dementia. It is chronic and not acute sleep deprivation that is a frequent cause of depression. It is an underactive thyroid that is a frequent cause of depression. And E, depression is about 40% frequent in Alzheimer's disease, so it cannot be considered rare. Nobody got it. Nobody responded. That was good. Okay. Confabulation. Yes, thank you. It is sign of real dementia that I did not remember that. Okay, so
1 hour.
any questions at this point? Again, so confabulation is when patients respond with an approximate answer. Any questions? No. Okay, so then we will reconvene at 1 p.m.
Doctor, I'm going to also run the attendance poll at this point.
Okay.
Okay, so we are done, right?
Just a minute.
Okay.